to see the diagnosis of brain death. So we have the clinical ones and the clinical examination. So they will be the paraclinicals. So in the clinic we will see that the patient has a systolic blood pressure less than 90 millimeters of mercury. The temperature, the patient is unable to maintain it above 36, so it will be below 36 degrees Celsius. Also, if we have just the acute event, a traumatic brain injury or something that the patient is already giving us the clue that the patient could have come from a trauma to the head, not only being on the bed in the hospital, but also on the hospital we need to assess when the patient has brain or is brain dead, that is legally the same thing as death. So now the paraclinics would be, we will see the perfusion of the brain. In order to see the perfusion of the brain, we could do it with nuclear medicine, SPEC, or we can do it with arteriography. The arteriography could be like the gold standard. If we have this, there is no other test that we need to do, but this is very cost effective. The Doppler of the neck vessels, that is, we can see blood flowing through the common carotid and external carotid, but if we don't see flow through the internal carotid, that is the one that supplies the brain, then that is a brain dead. Also, we could see evocated potentials of the brain stem. These could be peripheral ones, like the auditive ones, and we will see a different pattern of waves, etc. There will be no movement response, and apnea, no response to the apnea. So we will see this doing the apnea test, and if this is positive, the patient is brain dead. That is, first we need to put the patient on a situation at 100% oxygen supplementation and a normal temperature of the body. So at 35 degrees Celsius, a little more. So in this, we would now unplug the ventilator, and if we see by the gas analysis, for example, arterial blood gas, that the partial pressure of carbon dioxide is above 60 millimeters of mercury or above 20 millimeters of mercury above the baseline, and the patient is not doing any movement of respiration, then this is a brain dead. The patient is not doing any effort to this highly partial pressure of bicarbonate. So this would be the equivalent of brain dead. The other thing is a EEG without activity, or a EKG with no electrical activity, or arrhythmias like ventricular fibrillation. So when we want to give the family members the report that the patient is brain dead, that is almost as saying that the patient is dead. So we are not going to say it like that. We need to be empathic with the family members. So because we would not say this if we are not sure. So look, there is also loss of the reflexes of the brainstem. So we have the mesencephalic ones, the ones of the pons, and of the medulla. In the mesencephalus, we just have the direct, consensual, and near reflex of the pupilla. The ones that we test are usually just the consensual and the direct. In the pons, we have the corneal reflex and the mandibular reflex. On the pons and medulla, we have the vestibulocular, and here we also have the oculogyric. And here we have the gag reflex, cough reflex, etc. So now, and the apnea reflex, that is on the respiratory center is on the medulla. So now, the order in which these are going to disappear are first the mesencephalic ones, then the pons, and then the medulla. So the patient could come in traumatic brain injury, and we see that there is no reflexes on the mesencephalus but do on the pons. Alright, so we try to do everything, and in a while we test again the reflexes, and now the ones of the pons are lost. So in each time that we are testing the patient and we see that it's getting closer to brain death, we need to inform the family members, like, this is the situation, that the situation is severe enough, and that the patient has lost now just the mesencephalic reflexes, but in a while now we said now the patient lost the pons reflex. So we are preparing the family members that we're going to say that the patient is brain dead until we have all the criteria, but also we are not going to not say anything and give them the expectative that the patient is going to survive when we're seeing that this is going closely to the brain death. So when the patient is brain dead, we can stop all the treatments, or that is what can be done. But if the family says no, continue the treatment, in a sense, that is, we don't want to continue the treatment in something that is not going to work, because we want to save the resources by the other patients. But it depends. For example, if we see no electrical activity on the heart, compared with fibrillar ventricular fibrillation, the patient at the end is going to have the death or brain death, but the time at collapse is different. If we do this, depending on which stage is the patient, we would do that the collapse occurs faster than normal. That is, faster than if we have not disconnected the patient. But we are not going to unplug the patient if the family asks us not to do so. Obviously, we need to define also what is dead. That is dead, brain dead. The patient is not going to survive if it has brain dead, but the heart can be still pumping. And if the heart is still pumping and the family members want to continue the treatment, well, we will continue the treatment. So this is the diagnosis of brain death. We need to have the clinical criteria and these confirmatory criteria. One test could be the apnea test. If this is positive, it is brain death. Or the arteriography also, but this is cost effective, so we usually don't perform this.